Welcome to our 2018 Public Health Ethics Forum, Minority Elders and Healthy Aging, sponsored by the Office of Minority Health and Health Equity and the National Center for Bioethics and Research in Healthcare at Tuskegee University. I'm Craig Wilkins, Senior Advisor within the Office of Minority Health and Health Equity, and will be serving as your MC today. It's a distinct honor to welcome each of our special guests, our plenary speakers, our session speakers, our discussants, our post-session presenters and other students, and our distinguished panel members. The purpose of today's forum is designed to reduce the gap in awareness regarding factors that affect healthy aging among minority elders. Experts in the field and distinguished group of elders will explain and illustrate these factors through data, programmatic activities, and personal experiences. This forum will address the epidemiology of minority elders in the United States, how to effectively recognize and support resilience among minority elders, challenges encountered by minority elders, the biological, social, and cultural factors that impact healthy aging among minority elders, and approaches for achieving healthy aging for minority elders. I had the pleasure of being part of a small planning committee that helped organize and plan this year's forum. My sincere appreciation and gratitude is extended to each of them for all of their hard efforts in planning this year's forum. Their names are printed on the agenda and also up here on the screen. I would like to recognize them with a round of applause after I call off each of their names. Dr. Leandris LaBird, Dr. Reuben Warren, Dr. David Hodge, Captain Drew Barrett, Dr. Karen Boyer, Dr. Denise Carty, Wendy Holmes, Heidi Holt, Tara Hurley, Jenny Kincaid, Uma O'Heary, Dr. Laura Ross, and Joe Valentine. Can we give them a round of applause, please? So again, on behalf of our planning committee, our office, and Tuskegee University, we appreciate your attendance and participation in today's forum. Before we begin today's forum, I have a few housekeeping items. If you didn't sign in before you came into the auditorium, please do so at the registration table. For each of you who register for the conference, you will receive a link to an evaluation where you can provide feedback about this forum. Look for the survey in your email box by next week. We really value your feedback, and your responses will be completely anonymous. For CDC staff and others viewing the conference on IPTV, we may not have your registration information, so please contact us at this email address, omhhe@cdc.gov, if you would like to receive an evaluation survey. For those of you who are watching online on IPTV and live stream, if you have any questions, you can also email us at this address, omhhe@cdc.gov. For those of you who are interested in receiving continuing education credit, please note this information on the bottom of the agenda. For those of you who've ordered lunch through Which, those lunches will be available on tables in front of rooms 246, 247, and 248, which is outside the auditorium. You take a right and take the first hallway on the right. On the agenda, after Dr. Redfield's remarks, the poster session will begin at 11:30. The posters will be located out in the foyer area. I would also like to ask you, if you haven't already, to please silence your cell phones, your Blackberries, and pagers. For our breakout sessions that will occur starting this afternoon, those breakout sessions that you will note on the agenda will be in 246, 247, 248. For our breakout presenters, AV support will be available at 12:30 to help you load any slides that you may have for your presentations. Throughout the day, I'm here to answer any questions that you may have. And now, to begin today's forum, I have the privilege in introducing to you Dr. Leandris LaBird and Dr. Reuben Warren. Dr. LaBird is currently the Associate Director for the Office of Minority Health and Health Equity at the CDC. In this role, she leads a wide range of critical functions in the agency's work in minority health and health equity, women's health, and diversity and inclusion management. She plays a critical leadership role in determining the agency's vision for health equity, ensuring a rigorous, evidence-based approach to the practice of health equity, and promoting the ethical practice of public health in vulnerable communities. The Office of Minority Health and Health Equity ensures a pipeline of diverse undergraduate and graduate students pursuing careers in public health and medicine through its administration of CDC Undergraduate Public Health Scholars Program and the James A. Ferguson Graduate Fellowship. Dr. LaBird has been instrumental in building capacity across CDC and in public health agencies to address the social determinants of health and identifying and widely disseminating intervention strategies that reduce racial and ethnic health disparities. She has skillfully executed innovative models of collaboration that have greatly expanded the reach, influence, and impact of the Office of Minority Health and Health Equity, and raised the visibility of health equity through peer-reviewed scientific publications, engagement with academic institutions, presentations at national and international conferences, partnerships with national and global organizations, and other communications and educational venues. Dr. Reuben Warren is professor and director of the National Center for Bioethics and Research in Healthcare at Tuskegee University, as well as the adjunct professor of public health, medicine, and ethics and director of the Institute for Faith Health Leadership at the Interdenominational Theological Center in Atlanta, Georgia. From 1988 to 1997, Dr. Warren served as the Associate Director for Minority Health here at CDC. During the years 1997 to 2004, he was an Associate Director for Urban Affairs here at the agency for Toxic Substances and Disease Registry. And in 2005 to 2009, he was an Associate Director for Environmental Justice at ATSDR. He was the Director of Infrastructure Development for the National Institute on Minority Health and Health Disparities within the National Institutes of Health in Bethesda, Maryland, from 2005 to 2007. Prior to joining CDC, Dr. Warren served as Dean and Associate Professor of the School of Dentistry, Department of Preventive Dentistry and Community Health at Meharry Medical College in Nashville, Tennessee. Dr. Warren is also a clinical professor, Department of Community Health Preventive Medicine, Morehouse School of Medicine, adjunct professor, Department of Behavioral Sciences and Health Education, Rollins School of Public Health, Emory University, both in Atlanta, Georgia, and adjunct professor in the School of Dentistry and School of Graduate Studies at Meharry Medical College in Nashville, Tennessee. His extensive public health experience at community, state, local, national, and international levels range from clinical and research work in the Lagos University Teaching Hospital in Lagos, Nigeria, to heading the public health dentistry program at the Mississippi State Department of Health. Please join me first in welcoming Dr. Leandris LaBird.
Thank you, Captain Wilkins, and good morning, everyone. Good morning. It's so good to look out and see all of your beautiful faces. Welcome to the Centers for Disease Control and Prevention, to our guests and to our colleagues. We appreciate the time that you're taking away from your desk to be with us today, and we know that you won't regret it. I cannot describe how excited I am to be part of this year's Forum on Minority Elders and Healthy Aging. We are all in for a treat. The Planning Committee has organized a lively, thoughtful, and inclusive program. A broad range of voices and perspectives will be heard today. This will not be an ordinary gathering of public health professionals. We have been privileged to partner with the National Center for Bioethics and Research in Healthcare at Tuskegee University to host these forums since 2015. The inaugural Public Health Ethics Forum was part of a year-long commemoration of the life and legacy of Dr. Booker T. Washington, founding president of then Tuskegee Institute and creator of National Negro Health Week, which has evolved to become National Minority Health Month that we celebrate every April. Each year that we've come together to plan this forum, I leave with history lessons that I would not have learned on my own. The breadth of my understanding of minority health, of public health ethics, and social justice has deepened in ways that wouldn't have happened absent this partnership. Tuskegee University is rich in its history of scientific discovery and conducting research, biomedical, agricultural, and social sciences research, among others, to improve the health status and overall possibilities of African Americans and others. The notorious syphilis study, which members of the Tuskegee community will quickly remind us was the U.S. Public Health Services study, marked a dark and hurtful period, but the university's reputation for excellence and leadership in science and research has not been marred. The Public Health Ethics Forums build upon long-established relationships with the Division of Sexually Transmitted Diseases and CDC's Office of Public Health Ethics. And I want to thank Joe Valentine and Drew Barrett for taking their seat at the table each year to plan this forum. Our goal each year is to examine and then call out ethical dilemmas in public health research and practice, particularly in our work to reduce racial and ethnic health disparities, in our work to improve women's health, and in our work to achieve health equity for all. This year marks the 30th anniversary of CDC's Office of Minority Health and Health Equity, and I am honored to stand on the shoulders of my predecessors, Drs. Warren and Dr. Walter Williams, to never lose sight of the vision where all people have the opportunity to attain the best health possible and to strive every day to realize the mission possible, which is healthy lives for everyone. If we are to achieve the mission of protecting the health, safety, and security of all population groups, these kinds of opportunities to bring together community leaders, scholars, students, public health researchers and practitioners, and national and local organizations are needed. Thank you for being part of the mission, and today's forum will leave a mark you won't forget. Thank you so much for being here.
Good morning. Dr. LeBert has said it all, so I won't belabor or repeat what I heard her say. I'd like to thank you for being here. There's a tremendous value in presence. Presence is a powerful message that all should hear. Not being a doctor, a lawyer, or whatever, not having 2, 3, 4, 5, 6 degrees, not having even traveled the world, but just being present. The power of your presence is what makes this forum important. If you look around, it's not crowded because we were intentional on who to invite. You're special. Everybody can't get into CDC. You know what you went through to get in. And you know what folk are still going through trying to get in. So just know you're special. The other part about this forum in particular is our focus on those who have been there, done that. You know, people lament about what it is to be old, what it is to be a senior, to be elderly. And those who have been there know. So we don't debate. And I say we because I'm 73. Proud of it. And when I say that to my students, to the students at Tuskegee, they look at me real strange, like, you're not even supposed to be alive. What are you doing here? And so what you'll hear today is those who have been there, done that. We discussed, we debated, how do we frame the conversation with the elders who have come? And what we've agreed, and maybe agree to disagree, is just being here for them is enough. They don't need a reference. They don't need a bibliography. Their presence tells a story. And so you'll hear from them and just know because they said it, it is. And if you live long enough, you'll find out. Let me take this last one before we get started, because the day is full, is to talk about the evolution of this forum. In times such as these, ethics is a critical part of everyday conversation. And everybody thinks they're right. And in some ways, everybody is. But our struggle, our challenge is to how do we come up with a collective right? That's public health ethics. How do we agree what is best for all of us? Not for you only, you're important. Not for you, you're important. For all of us. And so somewhere between what's best for you and what's best for us comes public health ethics. So we are supposed to debate. We're supposed to argue, if you will, and even disagree. But what we must agree on, what is best for the collective, is what we must do. That's what we will do. And last and most importantly, we're ranging from those who have been there to those who are coming. Please note the poster presentations on the outside. These young scholars, let me be clear, young scholars have worked hard to bring science to you. And I want you to look at it and challenge them. The power of their presence is what we're looking forward to. And the power of yours is more importantly. So again, welcome to this forum. We need to hear what you think is important. Thank you.
It's an honor for me to introduce our opening plenary speaker, Dave Baldridge. Dave is a member of the Cherokee Nation, a nationally recognized Native advocate for elder issues. Dave has served as Executive Director of the International Association for Indigenous Aging since 2003. Prior to that, he was Executive Director of the National Indian Council on Aging from 1992 to 2002. During that time, he published nearly 24 monographs and papers dealing with long-term care and elder abuse. Under his leadership, NICOA became the nation's foremost nonprofit advocate for American Indian and Alaska Native elders. The organization tripled in size while significantly influencing legislation and federal policies affecting Indian and Alaska Native elders. David's been actively involved in public policy and research efforts on the federal, state, and local levels. He has vast experience in the legislative, budget, and advocacy process, representing the interests of older American Indians to Congress, states, and tribes. He has testified before Congress on several occasions. He has twice served on the board of the National Committee for the Prevention of Elder Abuse and has been a technical assistant contractor to the Department of Justice Office of Violence Against Women, assisting Native program grantees. His accomplishments include leading national advocacy for the Older Americans Act, services for American Indian elders. He has authored numerous papers on Indian advocacy, health, demographics, and culture. His work has involved extensive relationships with tribal councils and organizations and sovereignty issues. His publications on a wide variety of Indian agent issues have been widely distributed and cited. He has interpreted Indian aging issues for congressional subcommittees, federal task forces, state aging organizations, long-term care providers, Indian organizations, tribal and intertribal councils. So please join me this morning in welcoming Mr. Baldridge.
Thank you, Captain, and good morning, everyone. I want to start our conversation about health ethics by looking at a few misconceptions that Americans have about American Indians and Alaska Natives.
Proud, forgotten, Indian, Navajo, Blackfoot, Inuit, and Sioux, survivor, spiritualist, patriot, Sitting Bull, Hiawatha, and Jim Thorpe, mother, father, son, daughter, chief, Apache, Pueblo, Choctaw, Chippewa, and Crow, underserved, struggling, resilient, Squanto, Red Cloud, Tecumseh, and Crazy Horse, rancher, teacher, doctor, soldier, Seminole, Seneca, Mohawk, and Creek, Mills, Will Rogers, Geronimo, unyielding, strong, indomitable. Native Americans call themselves many things. The one thing they don't.
Some of these perceptions are romanticized, others are derogatory. Are we noble savages or despicable heathens? Disney media concurs. In either case, the perceptions are damaging. They cause us to generalize our opinions of Indians, who are in fact neither saints nor sinners, and we don't always see them as other Americans struggling with the hassles of daily life, just like us. The romanticization of Indians is particularly common in Western art, which often portrays a live Indian maiden communing with a white buffalo who appears in the sky, or a wizened chief offering a peace pipe to the spirits. And I would say only on very rare occasions do these characterizations accurately reflect who we really are. So, who's an Indian, really? Well, it depends on who you ask. Elizabeth Warren, for example, claims, like many Americans, to have Cherokee ancestry, although her claim is undocumented. Cherokee interracial marriages were and continue to be very common since the 1880s, when this progressive tribe was moved from Georgia and North Carolina. For many thousands of Native mixed marriage descendants, accurate birth records weren't kept or were destroyed, and their only source of ancestral validation consists of family stories which were passed down through generations. Well, for who's an Indian, the federal government says an enrolled member of a federally recognized tribe. And it brings a question of who do we serve as an Indian? For public health, it's tribal members. The nation's 567 registered tribes occupy lands in 35 states. My own tribe, Cherokee Nation, the second largest in the country, has more than 300,000 members, many of whom live in other states around the nation. Tribal lands are 14 counties in northeast Oklahoma, and Cherokee Nation bases its membership on descendancy. If you can show that your ancestors were designated by the 1898 Dawes Act or other earlier federal census rolls, you can register a member to be a member of my tribe. For most other tribes, they base their membership on blood quantum, with requirements sometimes as high as 50%. The issue of tribal membership can become especially contentious when, say, a small tribe operates a highly successful casino, as in the case of several California rancherias. In those cases, tribal membership can be worth a significant fortune. Ever since our nation was founded, the Indian issues have been considered a federal matter, not one regulated by states. The federal trust responsibility exists as a mandate to provide health care and other services to Indians. It was established by Congress on the basis of treaties, statute, and case law. As Congress granted quasi-sovereign status to tribes, authorizing them to administer their own affairs, states and tribes have conflicted over issues of jurisdiction and services. Former chairman of the Senate Committee on Indian Affairs, Daniel Inouye, commented in 1998, I was there in Washington, that Indian legal issues are among the most complex in all American jurisprudence. Tribes and states continue to experience conflict over matters of law enforcement, criminal prosecution, gaming, and Indian child welfare. States don't provide health services for tribes and don't consider themselves accountable to the federal trust responsibility. That FTR, the federal trust responsibility, is critical to Indian country's survival, and it's the basis for public health entitlement in Indian country. But here's a little-known aspect. I point this as a very important one. The Cobell Commission's 1977 final report on trust responsibility said, quote, "The trust obligation extends not only to tribes as governing units, but also to their members, wherever they may be. There is nothing in the law which holds that the federal trust responsibility stops at the reservation gate, nor do sound policy considerations dictate such a result. On the contrary, consistency and fairness demand just the opposite," unquote. Overall, the census reports 5.2 million American Indians and Alaska Natives. Our population, fueled by a cohort of the youngest mothers in the nation, average age 23, means the overall Indian population will triple by 2050. Need to bump one here. Native baby boomers. a cohort which will grow by 700% by 2050, are now elders, with all the attendant problems associated with aging. Many boomers in Indian country are reaching the ranks of the old. And we continue, as we have for the past 30 years, to move off the reservation. About 4 out of every 5 Indians is now urban. My longtime colleague and friend, Dr. Mario Garrett, is a psychology professor at San Diego State University. He calls this the greatest demographic shift in American history. The reasons for this huge out-migration from reservations are multiple, and the effects far-reaching. The implications for public health are enormous. Our public health care delivery system, primarily administered by the Indian Health Service, is still based on a paradigm from the 1930s, when 90% of Indian elders lived on reservations. Today, that number is only 20%, 1 out of 4. The paradigm continues, however, to direct our public health services to tribes, not to individual Indians. Indians are moving away from reservations in remarkable numbers. We leave for many reasons, but we can no longer be considered, understood, or served as an exclusively rural population. We leave for our health. Most health indicators show that Indians die of higher rates compared to whites of TB by 600%, alcoholism 500%, motor vehicle crashes 230%, diabetes 190%, unintentional injuries 152%, homicide 160%, and suicide 160%. Devastating. Compared with the overall population, Indians, to put it mildly, have poorer health and higher poverty rates. The federal trust responsibility, our socioeconomic and political contract with Indian country, is clearly failing them. A few years ago, South Dakota Senator Byron Dorgan observed that men on the Pine Ridge Reservation have the lowest life expectancy, 55 years, of anyone in the Western Hemisphere except men from Haiti. Navajo Nation, America's largest tribe, is as big as North Carolina and has as many miles of roads. Their diabetes rates are 2.5 times those of the United States. At the Tohono O'odham, an Arizona tribe 200 miles south of Navajo Nation, type 2 diabetes remain among the highest in the world. We leave the reservation to escape poverty. On San Carlos Apache Reservation in southern Arizona, 25% live in extreme poverty, 6 times the national average. We leave to escape despair. Indian youth have the highest suicide rate of all comparable ethnic groups in the United States. It's the second leading cause of death for Native youth aged 15 to 24. Hopelessness is rampant on many reservations for our youth. Nearly 77% of American Indians have a high school education. But inversely, on Navajo Reservation, again for example, only 1 in 4 are high school graduates. This picture holds true on at least 9 other reservations, and probably many more. It doesn't bode well for Indian country's health literacy. We leave for careers, but only 5% of Indians and Alaska Natives have received graduate or professional degrees, compared to 10% for the total population. And only 9% of American Indians have earned bachelor's degrees, compared to 19% for the U.S. population. Very few career opportunities are available on reservations, so we migrate, which continues to fuel this massive migration. So, the effects of out-migration on reservation elders, when their sons and daughters leave, what happens to the reservation elders? As younger natives migrate away from reservations, fewer family caregivers remain to take up the slack. The CRI. Some years ago, Dr. Mario Garrett and I created a report for CDC featuring the Caregiver Ratio Index, or CRI. It's a ratio of how many younger adults there are in a community for every older adult. The figure tells us how many younger potential caregivers exist in a community for every older adult. The results showed great diversity among Indian communities. Some have a CRI of 6, others of 0. Low score or low ratings indicate that these communities don't have informal support systems to rely on, whereas for many Indian communities, more than 90% of elders are supported by their children, especially female children. In some communities, this resource, because of out-migration, doesn't exist much anymore. The U.S. Census tells us that in the 1940s, 8% of Indians lived in cities. In 1970, it was 38%. In 2010, 78% resided in cities. Today, more than 80% of Indian people live outside the reservation in what are known as urban areas. This brings a real challenge for public health care systems. Urban Indians are often not able to get IHS or tribal health care except back at their tribe, which may be hundreds of miles away. Urban Indian centers have a multi-tribal service population. The clinic in Oklahoma City, for example, serves Indians from 114 tribes. It's huge. Many will be low income, often socioeconomically and educationally disadvantaged. They may have low levels of health literacy and may not have access to health benefits coordinators or advocates in the cities. Leaving the res, well, it's a big step. It means loss of tribal law enforcement, the tribe's judicial system, local health care, and social services. These are not available directed to Indians in cities. It means loss of tribal social and religious ceremonies, and probably most of all, it means loss of a close-knit community which shares common values and informal social supports. Urban Indians in cities tend to scatter, not living in ethnically intact communities or neighborhoods. This makes them more difficult to serve, and again, they usually have to return to their tribe to get primary care. Urban Indian centers. Public health for Indians continues to operate under an outdated paradigm that provides almost all its services to reservations. In the new Indian America, demographically, the paradigm is no longer valid. Indian health care is provided by what we call the ITU system, meaning IHS, tribal and urban. IHS delivers care through 26 hospitals, 59 health centers, 32 health stations around the country. That's a lot. Tribes and Alaska Native corporations run 19 hospitals, nearly 300 health centers, 80 health stations, and more than 160 Alaska Village clinics. 38 Indian clinics exist in the nation, although with limited funding, their services are also usually limited. The Indian health care budget, the root of all evil, the root of most evil in Indian country. The Indian Health Service has provided Indians with health care since 1955, including both primary and public health care, along with facility construction and maintenance. It uses a system of providers in 12 geographic areas. Under compacting and contracting regulations, though, several hundred tribes, known as 638 tribes, now operate their own health care systems with money that previously was allocated to IHS. They, too, operate under the same enormous budget shortfalls. In 1992, I was new in my job in Indian advocacy, and I learned there were only 3 tribes in the whole country that were taking over their own health services. They do a better job often than anyone else because they're so culturally couched and culturally appropriate. Now that number of 638 tribes is greater than 400, maybe greater than 500. It's been an enormous shift in the delivery system. So the IHS mission has been impossible to achieve due to historical, chronic, and severe underfunding. By comparison, the 2018 VHA, the Veterans Administration, has a medical budget of about $86 billion, more than 14 times that of IHS, while serving a population that's only 4 times greater. Indian patients still receive only 1/3 the per capita health spending of the general U.S. population. This is a fundamental reason why reservations and tribal villages continue to suffer third world conditions and documented poor health outcomes. Life expectancy averages 4.5 years less than that of other Americans, and even as high as 20 years less on some remote rural reservations. In 2010, 78% lived in cities. Historically, less than 1% of Indian Health Service funding goes to grants and contracts for services to urban Indians. Less than 1% of the budget for 80% of the people. Probably the first public health initiative for Indians occurred in 1763. When Geoffrey Amherst, commanding general of British forces during the French and Indian War, distributed smallpox-infected blankets to the Indians, quote, to extirpate this execrable race, unquote. The resulting resilience of Indian elders is evidenced in part by their survival of this and other genocidal atrocities that occurred sometimes more than 100 years later, notably at Sand Creek, Colorado, and Wounded Knee, Montana, where hundreds of men, women, and children were slaughtered. Today, although plagued by health and socioeconomic disparities, which remain huge, the well-being of Indian elders remains one of the highest values expressed by the nation's 567 tribes. They are revered as wisdom keepers, examples of courage, and spiritual leaders. They have served in the U.S. Armed Forces at 3 times the rate of other Americans. Public health messaging works for Indians when it is. The successful public health initiatives that follow share some things in common. I'm going to name 3 or 4 of them that I think are wonderful examples. They all use Indian providers, both organizationally and personally. These programs are not only conducted by Indians on the ground, but have been created from the outset with Indian input. The Eagle Books were designed by Georgia Perez, a Pueblo woman, and implemented by CDC's Native program. The IHS Special Diabetes Program for Indians began supported by the Tribal Leaders Diabetes Committee, Indian Direction, Indian Input. The Palliative Care Program at Fort Defiance began with strategies of the IHS Hospital's palliative care team. They were all Navajo local residents, deeply couched in their culture and friends with their neighbors. Let's look at the Eagle Books. By the way, thanks to Delight Satter, these are available at the table during the break outside. We have sample copies for you. They have been a spectacular success for us. It was created the series of 4 books was created in 2006 by CD's Native Diabetes Wellness Program. Targeted to children ages 4 to 9, it features animal characters, a wise eagle, a grateful rabbit, a clever trickster coyote, and 4 young native friends who promote the gifts of healthy food and the joy of physical activity. More than 3 million of these books have now been distributed around the world. The first year alone, requests came in from as far away as Pakistan and Argentina. Dawn Satterfield, director of the CDC Native Diabetes Wellness Program, just had surgery and can't be with us today, but she's arranged, thanks to Delight's help, for copies of the book to be available for you guys. At the Smithsonian, In 2008, CDC convinced the Smithsonian's National Museum of the American Indian to host an exhibit of 72 paintings, the book's original artwork. After a long show at the museum, the books were featured in a traveling exhibit through the eyes of the eagle, illustrating healthy living for children, which visited dozens of tribes over the next 6 years. Another spectacular public health success began when Congress established the Special Diabetes Program for Indians, the SDPI, in 1997 to address this growing epidemic. These tribally based programs have become the nation's most strategic, comprehensive, and effective effort to combat diabetes and its complications. SDPI currently provides grants for more than 400 programs at tribes in 35 states. Another great example, despite multiple researchers concluding that discussing negative information like end-of-life care was considered culturally offensive and potentially harmful by 86% of Navajo elders. In 1990, at the Fort Defiance IHS Hospital, Dr. Tim Domer and his native team turned that conventional wisdom on its head. Using a new approach based on PACE, the Medicare hospice benefit, and Eric Coleman's care transitions model, this team increased patient completion of durable medical powers of attorney from 4% to 89% and advanced directives from 1% to 85% over 9 years. Wow, those numbers are far above national averages. Working at this remote reservation location with a highly traditional service population, Domer said simply, "We work to build trust." To their great credit, CDC, the Alzheimer's Association, and other national organizations have collaborated since 2001 to create a national public health agenda through the Healthy Brain Initiative for addressing Alzheimer's disease and related cognitive health diseases. The agenda is expressed through a series of roadmaps designed to define and implement a series of collaborative goals and actionable objectives or action items for our public health system. The first two roadmaps covered the periods 2000 to 2018. The next one for 2018 through 23 will include, for the first time, American Indians and Alaska Natives. Earlier this year, the Alzheimer's Association contracted with my team, the International Association for Indigenous Aging, to conduct 2 national consultative webinars, one for tribal health directors, one for tribal senior program directors, to learn their thoughts about the roadmap and the effects of Alzheimer's in their communities. We learned that really no systematic initiatives are in place to address this crisis. The HBI, for the first time, will now include an Indian country component, and it is launched through consultation with Indians. So, where does that bring us? On August 19th through 22nd, in the year 2000, more than 1,000 Indian elders from 105 tribes came together at Duluth, Minnesota for the National Indian Council on Aging's conference. For 3 days there, inspired by messages from tribal and spiritual leaders, the elders deliberated, then created a spiritual message to America. I quote some excerpts from their message. "We pray that we can respect the diversity of America. All life is sacred. We pray to learn ways to settle differences peacefully. Teach respect for each other's ideas. Value honesty on all levels, from children to parents to community to governments. We will be happy only when we create peace with each other. To the 7th generation, survive. Keep your hopes and dreams. Take care of yourself. Remember your spirit. Be there for each other. Respect courage. Share knowledge. Always keep learning. Remember your true values." If we listen to them, we'll be okay as their public health partners. Thank you very much.
Thank you, Mr. Baldridge, for a fantastic presentation. We have a few minutes now for any questions for Mr. Baldridge at this time.
Yes, go ahead. Sorry.
Thank you so much for that perspective on Native Americans and the journey that they've been on in terms of their health care and throughout the last many years, the struggles that they've been up against. What would you suggest would be next steps for us in terms of solutions to some of these problems and inequities in service delivery?
The elements that have made our public health programs successful in the past are just key. At the very top of the list, I've been told that the most important issue for every tribe in the entire nation is self-determination. And so often we bring our programs to them top down. The program is developed, and then we'll see how we can implement it in Indian country. These successful programs, some that I've described, have started at the conceptual level by including Native people, whether it be tribes or Indian organizations or experts about an issue. But that involvement from the start seems to be a fundamental key level. So I'd say develop every program with Native, Native partners from the very start.
Thank you.
And thank you for your question.
I have a question.
Yes, ma'am.
Yes. I'm sorry I was a little late, but what is the predominant three tribes that are concerned with the issue of, in the conference that you attended, the issue of Alzheimer's disease?
That's a good question. What three tribes
The predominant three tribes
are dominant in the consideration of Alzheimer's disease?
Yes, and I'm sure you covered placement, such as Emory has rehabilitative hospitals, and Emory has assisted living program of that sort. So what kind of placement facilities or does that exist?
Very good question, too. Earlier this year, the Administration for Community Living, the ACL, issued $5 million worth of Alzheimer's and related dementia grants. Some went to states. Another category included nonprofits / Indian tribes. Because the need is so great in Indian country, my organization started identifying tribes that were deeply involved and eligible to apply for these grants. In order to apply, you have to be a member of an existing coalition that is addressing Alzheimer's and dementia locally. We searched for 3 months. We could not find a tribe that is part of a coalition. We ended up talking with the United Nations in Wisconsin. They are a tribe that's very capable and are part of a small state coalition, but essentially Indian tribes were excluded from the application process because we don't have yet coalitions in Indian country. I am sorry, I cannot name 3 tribes to you that are doing effective work with Alzheimer's disease.
Thank you. And the second part of the question?
You may have to remind
Sorry.
me what the second part of your question was.
The second part of the question, does that, I guess that response will be applicable also to the second part. Since there were no coalitions, then they were not eligible to receive part of the grants for placement for assistance. Is that correct?
Yes. Next steps we could take. During our consultative webinars, we got more than 40 responses from tribal health directors and tribal senior program directors. They indicated that the awareness of Alzheimer's and dementia is high and Indian people are afraid of it. yet nothing programmatically is being done to address it. We're not getting early diagnosis from physicians. We don't have community programs on the ground to help with stuff. And so my thinking is that we would start with intertribal councils. There are a dozen of these around the country. They range from the Northwest Portland Area Indian Health Board, which serves 42 tribes as its members, and the health directors of each of those tribes will be part of the board. The 5 civilized tribes in Oklahoma, some of the nation's largest and most progressive tribes, only has 5 tribal members. But the intertribal councils deal with the health interests of all of their member tribes, and I believe that's a really viable point of entry to Indian country. I hope that helps.
Thank you very much. Thank you.
Thank you, Mr. Baldridge. I was wondering what your kind of advice you might have for those programs, particularly at CDC, where most of our funding goes directly to states. And you mentioned that states sort of don't see their responsibility to the tribes. They see it being a federal responsibility. So how do we facilitate better relationships? Because I work in the Division of STD Prevention, and most of our funds go directly to states and city health departments. And so I'm really concerned because we also want to make sure all populations get the services that they need. So how do we build better bridges, and what can we say to states to help them better engage to working with Native American populations?
If I could answer your question, I would become the most famous Indian you ever met. That antipathy has existed, as I mentioned, for a number of years, decades. And we're finding cases now as America becomes more homogenous in many senses, Indians are far more acculturated. I mean, our baby boomers ride Harleys. Then partnerships are springing up between progressive tribes and progressive states. There are other states, I could name 4 or 5 easily, where the states have not supported tribal interests at all, and that antipathy still remains. But I think there are examples in many places now of emerging new partnerships between tribes and states. The need is so great, yet the states are strapped for money, just like the federal government in many cases, and they can't afford to target a special population that they don't have a mandate to serve specially. So a difficult one, but I think it's doable.
Right.
Yes, ma'am.
Thank you, Mr. Baldridge. Excellent presentation. You pulled together a lot of really, I think, important facts for us to think about as an agency as we're moving forward with our programmatic work. So my question is building on the question that was asked a minute ago about placement of individuals who have Alzheimer's or related dementia when they need assisted living or skilled nursing care, so in other words, long-term services and supports. You mentioned the caregiving ratio and how we're seeing people leave reservations and families younger, and we see this in some cities across all different racial ethnic groups, that the kids are moving out and leaving mom and dad there. And so I guess my question is, what is the picture of caregiving and support? So are there assisted living facilities? Where do American Indians and Alaska Natives go when they don't have family or other people to help provide care for them? So what happens? If you could tell us a little bit about that, please.
That informal care system has been profound for, centuries almost. And so I'm seeing a lot of elders who are caregiving for other elders. So if there's an out-migration of kids, we've got to work with who's left. I think some tribes are having success with localized programs. They have, for example, volunteer groups who meet to discuss Alzheimer's and what they can do as caregivers about it. And those programs are originally locally in the communities, and they're not funded. And they're sparse. Excuse me. For a second, there is a lot of denial, as you mentioned, there is across the U.S. probably, about the embarrassment of having a grandma with Alzheimer's. Families really value their privacy, and in small, isolated communities, that's a really valued and difficult commodity. So it's a family matter is a common response as we turn away from it. It's just a normal part of aging as we turn away from it. But we're just at a point in Indian country of recognizing our denial, for one thing, that it really is not normal and that it is a problem, behavioral health diseases. And so we have so far to go. And certainly, I guess from my perspective, we really need direction and participation with CDC. That's the best I can do for you. Sorry. So, anyone else with any comments or questions? Well, thanks. I really treasure my my history with CDC and being able to work on some of these projects, like with Lisa and with the Eagle books over the years. So please just keep the faith and remember those Indian elders' message. Stay strong, hold strongly to your beliefs, and they will lead us all to the heart of Indian country. Thank you very much.
And to introduce Dr. Reuben Warren, who will be moderating our panel session this morning. Dr. Warren.
This is a very special session because it's really targeted to those who need to learn something. So I suspect that means everybody in here. And what we really want to do is have a conversation. Thriving and aging with dignity. And the planning committee worked very hard to try to figure out what we were supposed to learn from this session. So we sat and we had discussions and debates about the objectives of the panel. What is it that we are trying to achieve? We talked about objectives, and so I'm going to read them to you so you can see if we accomplish them at the end of our conversation. To identify biases that compromise healthy aging. And I'm saying those so you can reflect on your own biases. I mentioned it this morning, students where I teach have a bias about me. So I say without apology, I'm 73. And they're shocked, so their biases are become very obvious. And what it says, what I take from that is that, what are you doing here, old man? That's the bias that I see in their face. Explore community understanding about the difference between being viewed as elderly and elder and an emerging elder, Dr. Georges. We wrestled with that in our panel, in our planning committee. Because I got offended. We started talking about elderly, and all the conversation was about dying and suffering. And I said, no, So let's shift the paradigm. Let's think differently if you can. And I'm sure when you finish listening to our elders, you will. Examining ethical considerations that should drive public health efforts related to achieving healthy aging. What should public health do? And most of the folks in public health are not elders. So I would argue that they ought to listen. And that's part of what we brought the elders here for us to do. Learn how to listen. And to assure social justice in the experience of healthy aging. Social justice, in my view, is public health 101. So that's what we intend to do with this group of elders. And so what I'm not going to ask them questions for them to answer. I'm going to read the questions and let them respond to the questions. But before I do that, I want to take one moment and let them introduce themselves, because I couldn't be so insulting to say, I know who you are, so let them tell you who they are. So why don't we start with my immediate right and just let one of our elders say who you are, your background and where you're from, and anything else you want to say. And we have a mic.
Yes, my name is Elias Segarra. I was born in Puerto Rico, USA, and I am 88 years old. And thank you. And it's funny, I have 3 cancers. They have been treated at Emory, and the one that's giving me now like more trouble is a bone cancer, and I'm getting chemotherapy for that, but I'm doing okay. I live in Duluth, and I'm retired. I look at what you were saying. I mean, every day. I mean, I live day by day, and I feel happy. I feel happy. I when I'm going to sleep at night, sometimes I get a little, and then I think of what I'm going to do the other day, what I'm going to have for breakfast. I have to prepare it myself because I live alone. But I feel happy. I watch my TV and my computer. I mean, I love my computer. Because of my computer, I read papers from all over the world. I read newspapers, and then if I cannot see the letters where I put them, I put them bigger, and I could say I'm living a happy life. Fantastic. Okay. And that's what I'm doing. Yeah, all right.
Nadine Irene Estanislao Cruz. I'm an immigrant from the Philippines. This year, my mother, who is alive, turned 97, and I turned 70, and our newest grandchild was born, and he's 3 weeks old. So this is a good year. I don't like credentials for myself. I think of myself primarily as a person who's searching for different ways of looking at things that are in front of our faces, like growing old and being at that stage in life where I think more closely or more seriously with intentionality about how to die well as part of living well and as part of being healthy. So I've worked mostly in higher education over 30 years in what is called public service education. So I've taught service learning, civic education, public service scholarship at various institutions in the United States, and I have also run a consortium of 18 colleges. So I've been connected with education for a long time, but I'm also a very, very deep critic of the very thing that I'm associated with. So my typical way is to be a critic of the conventional way of looking at things. So I will be speaking out about how I feel uncomfortable with how elderly and elder is defined, at least as far as I can, as far as I hear it around me. Thanks.
My name's Chester Anton. I'm from Arizona, southwestern Arizona, a member of the Thon Autumn Nation. Our nation borders on Mexico. And I've been primarily involved with healthcare as a politician, I guess you might say. But I don't lie. But yeah, I was in denial for quite a long time until CDC and Tuskegee told me I was elderly, so here I am. So yeah, we run into a lot of the issues nationally with the Native American population, elderly. And we talk about it, we try to figure out ways of how to serve. Because in our way, and most Indian communities, the elderly are special. They're honored. But as you'll see, some of the conversation may turn into a gradual erosion of what we used to be. But I'm here, so I'll be participating.
Good morning. Good morning. My friends. Yes. And I say you are my friends because you're here. My name, I'm going to give you a long name. My name is Mamie Viola Henry Watkins Clemens. And it took me a bit over 100 years to get here. To be here with you. Thank you very much. I guess you would like to know a little something about my background, which I don't have long enough to tell you about it. But I was born in Evergreen, Alabama. And when you think you're in Evergreen, you're a little further out to China, Alabama. And I was told by several, they don't know how we got to be there because it was back in the woods. I was fortunate to be born of two parents that were both school teachers. And to be able to go to school to your relatives, it takes a bit. But I'm thankful to be here to tell you a little something about it, my education, if you call it that. Able to walk to school while others rode buses to school. But we were able to be taught of things that would concern you later on in life, meaning that there's no stopping place if you really want to be somebody, so to speak. So I'm very grateful this morning to be here to tell you a little about life, education a bit. Being taught by my parents, then being taught by my brother, who moved from the country all the way to Tuskegee. And after Tuskegee, many, many other places. But I'm thankful, so grateful to be here now. Sound a bit repetitious, but that means that, so I'll be able to let you know, and you may want to ask questions after that. But able to go to school, to walk to school, after finishing 12th grade and moving to Alabama State Teachers College at that time, being able to teach on a provisional certificate, meaning that the community wanted you. I walked 2 miles to a 2-room school where 2 teachers taught and kept warm by a stove that wood was cut to make fire for the children in order to study. Moving from there, being at Alabama State University now, to Tuskegee. And you've heard a lot about Tuskegee, and you will be here about Tuskegee. Then receiving a BS degree from the University of Pittsburgh. Now I'm able to tell you a little about the school and the teachers that came from that 2-teacher schoolroom. We can point them. Huh? Yeah.
We're going to get to that later. I've been knowing Ms. Clemens for a long time, and she told me she ain't made me. So just want to let you know, this ain't made me. Let me ask, that was the answer to the first question, so I didn't have to ask. Tell them something about yourselves. What I'd like to know now from the panel is what has most impacted your life? We're going to start at the other end. What has most impacted your life?
I'm trying to think about it, not so many things. But I believe my mother has such an important part in my life, mainly making me my personality as a positive person. I'm an eternal optimist, and the way she taught me at can I? Yeah. Can you hear me now? Yes. Yeah. Sounds like a commercial. Well, anyway, can you hear me now? The thing is, thank you for telling me. I was born, as I told you, in Puerto Rico at such a long time ago, and it was so different. We were poor, and it was different at that time. I know someone here has a lady that she has 101, but I have 88, and it was so different. But that was what most impacted me, was my mother.
Next.
What has most impacted me, I'm going to say it straight up because it's part of what I would like to share. There's a lot of stigma attached to it, is that when I was 3 or 4 years old, somebody came into our house, pointed a gun at my father, and gunned him down and killed him. My mother, during World War II, saw her fiancé shot and killed by an American soldier who thought they were the Japanese enemy because all Asians looked alike. Those killings are part of, I think, of intergenerational historical racial trauma. And a lot of what I have, when most of my 70 years has been focused on the particularities of my individual family. And it has taken me a very, very long time to see my family's health in the larger context of large swaths of history and social systems. And so that's what I hope to be able to share, is what I have struggled to figure out about my own life in the context of the larger historical drama, to figure out how to be a healthy, thriving older person.
What has impacted me the most in education? My mother, who really didn't know too much, made sure that I sat at the table and did my homework every night under the kerosene lamp. For her to do that made me pursue education at different times in my life and eventually make it out of the University of Arizona. And that's the first in our family. But the other thing that I think had more of an impact on me as far as how I view life right now as being something given to you by the Creator, that you should honor it. I came to that realization, but having to have lived through many dark moments. I'm an alcoholic for maybe been sober now for over 20 years. But that experience has taught me the value of life now. And I just want to be a part of it now and be happy and do what I can for the people.
The one most important thing in my life has been the prayer life of my parents. And the idea that was put into my head was that there's no height that you cannot reach if you are willing to pay the price all the way. So I've been impacted by people, dealing with people, knowing people, and being a part of their lives. That has impacted my life, to want to be a loving person and be loved by those.
This question is a little sensitive one. Give me an example of something that's been a bias or a prejudice to you. Something or some event, bias or prejudice to you. Yes, sir.
I studied in the University of Miami, Coral Gables, long ago. And at that time, I remember there was still segregation, which when I came was so strange to me because we didn't have that in Puerto Rico. But I felt segregated. What struck me once, it was like a chauffeur of a bus, and I handled him some money, and he made some comments. I can even recall it now, but I felt myself. He made some comments as to, because he heard my accent, as to derogative. And I probably couldn't understand part of it, but a friend of mine that was with me, he was from Cuba, and he heard it. He knew a lot more English than I did at that time. So he answered him, and I mean, that's an occasion I can remember what I felt like prejudiced because of my.
Thank you.
You're welcome.
There are so many that I would throw out a few. So I used to have hair below my waist. I chopped it all off because I could never, it seemed, establish a sense of my authority with the long hair. And so I chopped it off because nobody believed I was actually the teacher in the class. So where's the teacher? Well, I'm the teacher. Oh, you don't look like the teacher. That was one of many. Another would be like, oh, why are you so emotional? Followed with, why are you so analytical? And so either as overly analytical or overly emotional. And then the last one example, there are just so many, but I'll just throw out these three, is so I was invited to give a presentation on United States-Philippines relations. And at that time, it was during the dictatorship of Ferdinand Marcos, and I was working on a social justice movement on human rights violations under the dictatorship of Marcos. And then I included why the United States was implicated in giving military aid to a dictatorship for the containment of communism in Southeast Asia. And the response at the end of my presentation was not curiosity about anything. It was, well, why don't you just go back then to the Philippines if you don't like it here so much? So, a few examples.
My experience has been that acculturation in our native lives from things outside coming in has been most difficult. And I don't want to say anything about something that's true nationally among tribes, but in my particular tribe, it seems that acculturation has kind of led us to become like the federal government. And the same thing that oppressed us, we seem to oppress. We learned it. You look at our system of government, ours is a 3-branch government, but all that bureaucracy is the same. But we still argue with the federal government about their bureaucracy, which we inherited. And that has kind of like a negative effect on how we feel about Indian for our elders, because that's what I said earlier, that we're seeming to lose that which we had for our elders. We have an adult protection ordinance. Why? To illustrate that how far we've come to get to that point where we actually need an ordinance. And in long ago ways, we didn't. We didn't need an ordinance because it was just natural. You took care of your elders. Like you go on a hunt and you were able to get lucky to bag a deer. Your first time they go to elders, you don't get nothing out of it. Then after that, you always have to give some to the elders. So it changed from that due to the time period, and I guess that's what I wanted how to answer that question.
The great part of my life has been to be happy. To be happy and to make those around me happy. And whatever I could do to see happiness, even in the face of a child. If a child looked worried at school, I'd like to make him happy. And I've always thought of this. If you are happy, can anyone make you mad? If you can make me angry, then you're smarter than I am. Because I believe that. No way should we walk around sad, even though things may not go according to the way even others around you, they may go, or what you have seen or what you've heard. But you become that type of person that you can climb as high as the good Lord would let you go. That's why.
I asked Aunt Mamie to give me an example of something bad or some prejudice. She wouldn't do it. She translated happy. No matter what I said about 5 times. It all came out happy. It all came out happy. The last question before we open it up for you to ask them questions is, what advice would you give our audience? What advice would you give our audience?
I would give the advice that to live this life, to live, is just a miracle. And enjoy your life and do the thing that makes you happy as much as you can. And enjoy doing that, doing what you really feel passionate about. For a long time, I tried to do what others thought I should do, and it didn't work for me. So, I mean, that's the advice. I mean, follow your vocation, whatever you feel like doing that makes you happy.
What did you mean by what kind of advice?
Any kind you want to give.
Oh.
It's yours.
For me, I guess the advice is what I'd like to share as an advice, what I've been trying to do, which is to develop some metaphors or pictures or visuals or vision of what it means to become elder and in the latter stages of the life cycle. And I don't know what it might be for you. It has helped me through a lifetime of chronic depression, which I think is a very stigmatized illness. In my community of Filipino Americans, they will cite obesity, hypertension, and diabetes, and won't say anything about the high suicide rates of female Filipino Americans. So some of my visuals are two, and I'd like to share that as an advice. One is that one metaphor I think of for myself to make me feel happy as a useful person is as an old growth tree. When you think about in the redwood forest, the old growth tree with all the roots interacting underneath the soil, all we need to do as an old growth tree is to stand tall and standing. Because then the new growth and the seedlings and all that, they can come. And we develop a big forest. And to a great extent, it sounds like a passive thing, but it's a very active thing, and it is centuries old. And so there is an inherent integral value to being an old growth tree. And if I'm a kind of human, the metaphor of an old growth tree, it is important for me to stay standing. And so that gives me incentive to overcome a lifetime illness of depression. The other visual that I use, and I share it as an advice, is the metaphor of the transition. So I transitioned from firefighting, which is like active, heroic, risk-taking at the barricades, physically fit, able to do lots of things, and feel useful that way. But I'm no longer firefighting in the sense that I don't have that part of my life anymore. But I can be weaving. And weaving is integral to the value of all communities. Weaving is invisible. It's not heroic, not seen as heroic. It's seen as feminine. It's everyday. But all communities cannot survive without the constant weaving of the fabric of humanity and community, and without the constant mending of that fabric. And I can do that even when I can no longer be physically fit. As long as I can interact with people, I can still have value as a weaver of society.
Advice. I think that when it comes time to go wherever we're going to go when it all ends, is to make your life, your characteristics, your values, and your traditions. You leave that in the memories of people that you've known, in the hopes that your life will have some value. Your life had a value, and hopefully it'll pass on to the people that remember you the way they do, because you have these good things about you. I think that would be the advice I would give, to live your life like that, to leave a good memory.
I learned early in life that prayer moves mountains. And I wanted to know, well, what is real prayer? So I brought to my knowledge from the Holy Spirit that I can pray in 7 W's and just about cover what God would have me be and do. the 7 W's of prayer. I will give them to you. You might want to write them down. Number 1, I pray that God's will be done. W number 1. That I really don't know everything about me, but there's some higher power somewhere that knows about me, what I need, what I can do, and all. So W number 1, I pray God's will be done. Number 2, I pray that it be done in His way. You know, when I started out to school, I didn't know exactly what I wanted to be, or even what I could be. But I remember that higher power knows all about it. So I want His will to be done in His way. We may not learn all that we want to know quickly, but we might have to bypass some things in order to get to the best things. I pray that His will be done in His way, the way He wants to do it. I may not know. I may not understand. So I pray that His will, His way, and then His word. We studied the word. Everyone knows something about the word Bible. So if it's according to His word, I know it's all right. His will, His way, His word, and then all I have to do is watch and pray. And while I'm watching, I have to wait. When I was teaching on a provisional in a 2-way school, I did not know that I could be 101 and be here and give you some knowledge of what I have gone through. So His way, and then I have to learn to wait. Wait till the proper time. I may not be able to do what I want to do, but there is a time element. His way, His will, His word, and then wait. And while you're waiting, don't forget, while you're waiting, there must be some work done. There's something you have to do. There's something you have to know. So that's His will, His way, His word. Then wait, watch, and then wait. Then continue to work. Because the word says, I must work the works of Him that sent me while it is day. Night cometh, no man can work. So we don't just sit and wait like we're waiting on the streetcar or bus. But there must be some work done. So then we work the works of Him that sent us while it's day. Night cometh, no man can work. And after we have let His will be done, in His way, through His word, while we just watch and pray, then we wait. We wait on the Lord. But we don't wait empty-handed. We wait while we are working. we continue to work. And you know, I thought about that work part, and I learned to work because when I would see this elderly gentleman plowing, and you may not even know what the word plow, but he was plowing a mule in order to raise vegetables. I would have him sit down under the shade tree and wait while I go a round or two and do what he did with the plow. And I was only an upper teenager at that time, but I wanted to help. And while I was waiting, and I saw an elderly person drawing water out of a well, turning a wetness to get water. And I stopped to help them draw water. And then with the drawing and the waiting, I had to wait until the cows that we milked, I had to wait until they grazed in the wood and come, and I had to draw water to give the animals water. And I thought to myself, looked like they never would stop drinking water. They were thirsty. So with that, and I repeated those several times, the 7 W's: God's will, His way, through His word, while we watch and pray, and then we wait on the Lord, and while we're waiting, we work. And after we have done that, you can feel like worshiping. You can feel like worshiping because you've done something that helped with it. So I am very thankful to have been able to see how to work and make vegetables grow so that we could eat properly and your health could be good. You'd be strong and mighty.
And I suspect you have some burning questions. Why don't you ask the elders a question that you might have?
Good morning. I'm Deborah Joseph. First of all, I want to say I am so proud of each and every one of you. I'm so thankful that you showed up this morning to share your knowledge and wisdom with us. And I'm extremely blessed to hear what you have to say, because you guys truly spoke from your hearts. And my question to whoever wants to take it is, how do we make sure that your voice is heard? Today, everything is driven by technology, and I hear from my mom all the time, she doesn't even understand what the computer is, so let alone turn it on. Or I was impressed when you said you read all the different newspapers on the computer, because I can't get my mom to even turn it on. But how do we ensure that your voice is heard, not only as we try to carry out this thing called public health, but to ensure that your messages keep going on from one generation to the next?
I'd like to jump in and suggest that maybe we shift from thinking mostly about the individual voice of minority elders to organized associations and groups. For example, in the Filipino American community, one of the assets, even though people keep saying all these risk factors, all these deficiencies, I keep thinking, why don't we think about the pluses? And the pluses are people congregate around food, music, events that are intergenerational. And so hearing the elder minorities' voice, I suspect, will be more sustainably heard if the unit of focus is a group, like the family or association. The joke goes, if there are 10 Filipino-American families in a town, there are 30 associations that are Filipino-Americans. They like to be in groups. There are groups for dancing, there are groups for meeting over food, there's groups over baptisms and weddings. People are always gathering, so I think that particular minority voice will be very well heard if we focus on the groups and not one by one through a survey or the usual methods.
I'm learning that technology so you can push that button and you'll have a mic. So I want to run around. Push the button on it.
Yes, my name is Specialist Truxton. I'm with the University of Losing Management team here at CDC. And I first want to say, I'm asking you this question as an older son who is now dealing with an 88-year-old father and an 82-year-old mother, a father who just came from beating colon cancer and is trying to rehabilitate, and the siblings and I are trying to step in now and help without hurting or making my parents feel like we're taking over or somehow not trying to take away from them still being the parents. My question to you is what are the things that we should avoid that might hurt them or make them feel that they don't have value to us as mom and dad anymore, or that we're trying to take over?
I think that just try to, or just listen to them. Be as much as spend as much time as you can with them, and that'll be, just listen to what they say, or whatever. You can just tell them, I want to know about this, and they can give you. There is so much. For example, I can give to my two daughters so much. They have their lives. They married late because they have circumstances. They have to work and study. But one of them is a doctor in medicine and a psychiatrist, and she has her time. She has only one daughter, but she has a lot of things that the other one is a veterinary doctor, and she is she owns a clinic, and she has two daughters. They are like, I feel sometimes like I myself am irrelevant. What you were implying, that there's nothing I can afford to give them to my. When I read, I print a lot. And what I do is I just give them the prints, because I know that if I tell them to go and go to a place in the web, they may not do it. But if I give them a printout, they may read it if they find it interesting. Making it short to make them feel that they have something to give, that the experience they have had in life is worth a lot. See, really, it is.
Yes.
And just listen. Just listen.
Thank you.
Just a few words. I think the main thing would be to communicate, talking about things. really you get what your elder wants. And just for an example, throughout our life, even though my mom wasn't sick, she always found a way or a time to tell us when she goes what she wanted us to do. That's in her control. We just listen and do what she expected us to do. So I think talking with your loved ones at that level is the best thing to do, because it also helps the family. There's no infighting over anything. It's just done the way it should be.
One thought I have, and I've struggled with that, my mom is 97 and has felt like we're taking over because she needs so much assistance and help, is I've found that I need to actually deliberately develop a, in quotes, curriculum, so that I don't, when I visit, start immediately with, we need to do this, and we need to do that, and there's this appointment, and there's a reservation, and what have you decided about this and that? So instead, I start with, here's a photo of the grave site of our father, your first husband, and we're trying to figure out, who's he related to. So I come with set up questions where it's valuable to me, but it's clear she's the one that has the source, so that every single interaction is a mutuality of needs, that I need this for the ancestry of my kids, your great-grandchildren, and I'm going to start there instead of, we need to do this, and why haven't you done that, and so there's a practicality to it, but always softened, I guess, by a mutuality of needs that isn't quantifiable.
Thank you.
Okay. As speaking of what you learn along the way, and learning to meet people where they are, not trying to make them what you want them to be or what you think should be, but in order to meet them where they are and receiving their attention. As I sit here and as I look, I think I've seen every face in here, because my mind has gone in that direction in dealing with students, in dealing with auditoriums full of people. I can look and tell the ones that are bored. I can learn and tell. There are some, I have looked at you already, that you have made my life better, because you have looked like you were interested, whether you're not or not. And I can, so as I look, I can pick out a few people. I could point out some right now. I could pick out a young man that has listened to every word I said, and he has listened. And then I've seen others that said, well, they didn't stop. Enough. Yeah. When are they going to quit? When they going to quit? They said the same thing over and over again. I've heard that before. I've heard other people say the same thing. And now, here they come with the same old story. Bring me something new. I appreciate you all. There might be questions.
This is more.
Is this one?
This question down here.
I'd like to know, like, when sometimes I try to remind my mom, she's like 89 years old, and I have to remind her all the time, to take her medication at a certain time. And she tells me, she said, I can't go down there. They done went up on the expense of it and everything. So my question is, how do you feel about the prescriptions or the way your doctors take care of you as far as the insurance companies or your medications and stuff? Do you feel like you're adequately taken care of as a senior citizen? I mean, do you think the doctors or the pharmacists are they just as attentive to you enough to make you feel like that they're taking care of you, doing the best they can to help you? Do any of you feel like they're neglecting you in some fashion? Or do you think the government is shortchanging you in some fashion?
I would like you to clarify what the questions are you have.
Well, how do you feel about the way your doctors that you go see for treatment, how do you feel about the way they take care of you? Or whether or not they're your insurance companies that give you, care that helps you out, pay for your medicine and that. Do you think your doctors give you enough adequate care, from the insurance that you have?
I feel like maybe I'm expecting too much, but sometimes when I go in to see my physician, and I think we get, as a system, Kaiser Permanente in California is an excellent system, I feel the absence of an understanding of aging. Because I go in and I say I have these aches and pains or whatever, and I can't tell if that would have been the case for a 20-year-old, a 30-year-old, a 40-year-old, an 18-year-old, or it's part of aging. And when I ask, is this part of aging as opposed to, I don't know, some other, it's a symptom of some other thing? The reason why it matters to me is because I feel like if I know that it's part of aging, then my expectation for my acceptance of it is different than if, this is a sign of some big trouble that we really need to correct at age 30, 36, or 40. Whereas if this pain is going to be with me for the rest of my life, I need to begin to have a transition within myself that this body is going to be aching like this for the next 20-some years. If my mother's age of 97 is an indication of how much longer I'm going to live, then I need to expect to live like this for the next 25, 30 years. And often the physicians don't know the difference between a symptom of at this stage in life as opposed to some other stage in life. And there I feel that there is a deficiency, even in excellent medical systems that don't have any gerontology background.
That's right. That's right.
I myself, I feel, I have so many things that are wrong with my body mainly, because my mind is okay, but there are so many. I have so many doctors. I tell you, mainly I mean my social life is with doctors. I myself, but my father was a doctor, a physician, and he used to say that if you would allow the patient to talk, he would bring the I'm lack of words, the diagnosis on a silver plate. Just listen to. And sometimes, I mean, the way the system is, some doctors, they just want to leave. They don't want you to explain. And then that, together with the fact that I am in lack of words due to my lack of whatever, and my brain is not working the same as when I was 30 years old. And but as a general rule, I mean, I feel that I am getting a very good medical care here in Emory. In this oncology department, I am getting good service. Okay.
I found out this. We need doctors, but I found out a doctor can only do for you what you have already kind of explained to them what's happening. If we can remember in going to doctors, doctors are not mind readers. I said that again. Doctors are not mind readers. I didn't get anything from that. Maybe you think doctors are mind readers. They should read your mind and know what you are doing and not doing. But they can really only go by what you tell them, really to a certain extent. And you don't tell it all, they can't work with all. So we need doctors, that's all I can say.
Why don't we have a kind of a closing comment from each of our scholars on this stage, because we have to move on. So any closing remarks that you might wish to have, sir? Any closing remarks?
As to myself personally, I would stress the importance of your mind, of your attitude. It's so important. I mean, I go to, for example, to Emory in oncology, and I just like everybody there. I love the nurses. I love the doctors. I mean, it's God really is love, I believe, and I feel myself good when I'm in contact with persons, and that makes me feel good to just that. I mean, be appreciative of that they are doing for you, and that they are human beings, and that they may have days where they are not really, I mean, too likable. But when I have nothing to give, I give a smile. I smile, and I love people, and that makes me feel happy. And that's so important. The mind is so important. Even though I got, like I told you, so many doctors, specialists in that, specialists in that other. And then I have an agenda. And then today I have to go, sometimes I have to go to 1 in the morning or 1 in the afternoon. And I keep, medicines, I have these timekeepers, because I have, in the morning I have to take a medicine, wait half an hour, and take another one, wait 15 minutes, and they take about 20 of them. I tell you, I have sometimes difficult swallowing it, but I have found a way. I just swallow them, and I'm doing fine. I love life. I don't want to die. No, I love Mike.
Well, since the title of this is Minority Elders and Healthy Aging, I can't help but think about how my individual struggle for health has got to be in the context of so many minorities across the decades have suffered as peoples histories of oppression. And I can't help but think that my individual struggle to be happy can't happen without an understanding of how that is in the context of my peoples having been oppressed and having suffered intergenerational historical racial trauma. And that seeps into life in ways that, because we're in the water of it, becomes so everyday and ordinary that it becomes like part of the accepted by nature almost. So when I think even of my mother, who as a widow with 2 kids became a professional, she adopted all the ways of modern European-based medicine and abandoned all the various Filipino indigenous native practices that now we're scientifically studying and saying, oh, these are really good things to do. These herbal medicines, these etc. Now we have scientific validation of it. But that was part of her colonial mentality. So she adapted into the imperialist paradigm, abandoned what was ordinary and everyday and accessible without expensive prescription medication. And so I feel like part of the challenge with minority elders and healthy aging, I think, is for somebody to do the R&D work, the labor, to somehow put everything together and make it into an integrated whole. So that what was abandoned because oppressive imperial colonial heavy erasure of what was known to people becomes integrated with modern medicine. And that somehow I have a feeling if we can do that, that would be part of the healthy aging of minority communities.
My closing remarks pretty much at the same line as my colleague here. But there's a thing called that we came up with. It's called the Cultural Wisdom Declaration, wherein we declare that we know that our traditional practices work. We're also asking federal agencies, any agency that has resources, that they need to work with us. CDC is a good example of at least one. Good Health and Wellness in Indian country. That happened over a series of 3 meetings with traditional healers, development of that language, finalized it, made a part of that grant. I think that's where we need to go now, to include us rather than do something for us. We need to do it with us.
I know you probably would like to hear maybe something that you think maybe would keep you healthy, wealthy, and wise. You would like to get a certain age or you wonder maybe how a person got that age. One thing, be happy, make others happy around you. Do what you can do for yourself. Only depend on others for what you cannot do. I can still cook good food, clean food, healthy food. I can still do it because you keep doing. Don't stop doing what you can do. Don't stop doing what you think you can do, because sometimes your thoughts will carry you astray. Continue to do what you can do. Yes. I say it again. I'd like to repeat it again. Do all that you think you can do, even that you think you cannot do. Make a try. Try it for yourself. When I broke my leg, as I'm in these chairs now, broke my leg in 3 places. It was healed. I won't say that. Go ahead, say it. It was healed, I won't say without a doctor, but they didn't have to cut it. They didn't have to do that. But I look to that higher power, God, that has done all that for me, because I made the promise to myself and to others that all that I can do, if I'm preaching, I can preach from a wheelchair. Nothing is wrong with my mouth. I may not hear as well, but they made hearing aids. Sometimes they don't work well. I don't see as well at times. I wear glasses. I would be looking terrible if I didn't have my dentist to make some teeth to make me look a little better. So my hearing, my seeing, my talking, I'm still adhering to what I'm saying. I know what I'm saying. I know where I am. Those are big things that we can do for ourselves to continue to live and live on. I said that I was going to keep preaching if I have to preach from a wheelchair. And you know it happened. I said, they made all these things. I started out with one cane. I walked with one cane. They told me about the double cane that you walk with and take steps. I tried that too. I got one of those. Tried that. Then they said you can move better if you get the one with the wheels on them. I got the one with the wheels on it. You know, they said you can push your own self. And I learned to go to the bathroom by myself, which was very healthy. Here I am today, all the way from Pittsburgh, Pennsylvania. And we had the doctor even got a hitch so it could bring my standby with me so that I could look good, feel good, travel a little faster, you know. It even has speed on it. I was told by one of the officers when we came in the gate out there, he said the speed limit is, you can't do it. I had been told that I sometimes could speed. So I've been watching this speedometer. I've been watching this speedometer to be sure that I'm not speeding on these grounds around. So you can take this. You can be happy. You can be happy. I was even happy at a funeral. Had the people laughing at the funeral. So, and I said that I would keep talking as long as I could remember to get my noodles right up here and not say too much. If I could listen a little more and speak a little less, then I could move on. And you come to the next stop. So I just say again that this is a wonderful world. Keep living in it. Keep helping others to live better. Keep helping others to feel good about themselves. Because if you don't feel good about yourself, nobody else is going to do it.
Yes.
So we do it, and I appreciate that. I still cook. I still can cook. I still can wash clothes. I still can be clean. I can still wash my body and still smell good when you hug me.
Let's stand up and thank them. Let's stand up.
One thing I say to you, and I got that from William Cullen Bryant's. William Cullen Bryant's Thanatopsis. I try to remember something from school. The last verse of Thanatopsis says, "So live that when thy summons come to join that innumerable caravan which moves to that mysterious realm where each shall take his chamber in that silent hall of death, thou go not like a quarry slave to his grave, soothed and sustained by an unfaltering trust. Approach thy grave like one who wraps the drapery of his couch about him and lies down to pleasant dreams."
Doesn't get any better than that. Does not get any better than that.
Thank you. I am very pleased and excited to be able to introduce the CDC director, Dr. Robert Redfield, who has been with us for not a long time. He arrived in March of this year. Dr. Redfield is the 18th director of the Centers for Disease Control and Prevention and administrator of the Agency for Toxic Substances and Disease Registry. He has been a public health leader, actively engaged in clinical research and clinical care of chronic human viral infections and infectious diseases, especially HIV, for more than 30 years. He served as the founding director of the Department of Retroviral Research within the U.S. military's HIV research program and retired after 20 years of service in the U.S. Army Medical Corps. Following his military experience, he co-founded the University of Maryland's Institute of Human Virology with Dr. William Blattner and Dr. Robert C. Gallo, and served as the Chief of Infectious Diseases and Vice Chair of Medicine at the University of Maryland School of Medicine. Dr. Redfield made several important early contributions to the scientific understanding of HIV, including the demonstration of the importance of heterosexual transmission, the development of the Walter Reed staging system for HIV infection, and the demonstration of active HIV replication in all stages of HIV infection. In addition to his research work, Dr. Redfield oversaw an extensive clinical program providing HIV care and treatment to more than 5,000 patients in the Baltimore, Washington, D.C. community. He served as a member of the President's Advisory Council on HIV and AIDS from 2005 to 2009 and was appointed as chair of the International Subcommittee from 2006 to 2009. He is a past member of the Office of AIDS Research Advisory Council at the National Institutes of Health, the Fogarty International Center Advisory Board at the National Institutes of Health, and the Advisory Anti-Infective Agent Committee of the Food and Drug Administration. Please join me in welcoming Dr. Redfield.
Thank you very much. Thank you very much for the kind introduction. I also want to thank the co-sponsors, the Tuskegee University's National Center for Bioethics and Health, and CDC's Division of Sexually Transmitted Diseases, and our Office of Minority Health and Health Equity. I also want to recognize the 30th anniversary of the Office of Minority Health that works to advance health equities. And I want to thank all of you for coming to be part of this, because someday and sooner, because of the efforts of people like you, health equity will become a reality. Life expectancy has come a long way in the last half a century, and we need to do a lot to improve the lives of people over 65 for all Americans. As you reflect back in 1900, the average life expectancy for all races was about 47.3 years. And by 1970, it had jumped to 70.8 years. Probably one of the greatest achievements in public health and advances in the 20th century. Leading causes of death have changed just a little slightly. In 1950, the top 5 causes of death were heart disease, malignant neoplasms, vascular lesions that affected the central nervous system, accidents, particularly motor vehicle and all other accidents, and early infant mortality and disease. In 2016, it remained number 1, heart disease. Number 2, the same, malignant neoplasms. Number 3 now was unintentional injuries and accidents. And then number 4 was chronic lower respiratory diseases. And then number 5, cerebral vascular events. So very minor changes, obviously, with infant mortality being one that obviously got off the list, and unfortunately pulmonary disease coming back into being one of the major causes of mortality. But recently, life expectancy's plateaued. If you look at since 2001, there's been an additional year gained in life expectancy, but between 2010 and 2016, really, it's not really moved at all. 78.7 years. The National Council of and Institutes of Medicine report, their study, looked at some of the gaps, particularly in the people over the age of 50, and they highlighted that since 1980, Americans have the lowest probability of surviving to age 50 compared to all other high-income countries. Older Americans reach 50 now. It's hard for me to say that 50 is older, but I guess it is. I guess, I'm kind of holding on to be 70 is older, but older Americans, which they said, those of us that reach 50 now, reach it in poorer health and face greater mortality from chronic diseases. And this is driven by a number of factors. Obviously, we still have a significant infant mortality rate. We have significant mortality related to drugs. We have significant mortality related to diabetes and obesity. We have they say we have the highest actually, for diabetes and obesity, among other countries. We have higher rates of heart disease. We have higher rates of injury and violence. And we have more adolescent pregnancies and STDs. And we have a high prevalence of HIV infection. There's not any one common thread that will explain. And obviously, Americans with healthy behaviors still have higher rates of disease. There are a number of social determinants of health that play important roles. Obviously, a very important recognition, the importance of social determinants of health as predictors of health later on in life. Americans' access to healthcare and behaviors greatly influenced by social factors in the environment, obviously lifestyle, health policies, and social values. All of these can influence what one's health status is, particularly as one crosses the threshold of 50 and beyond. But there are some good news for older Americans. Higher survival, actually, for those of us that live past 75. There's really higher rates of cancer screening and survival in those of us that are over the age of 75. There's better blood pressure control and cholesterol control, which obviously is important, as you saw that heart disease remains the number one. And there's lower rates of smoking. But life expectancy still varies between populations. Life expectancy today in the United States for Caucasians about 79 years. For African Americans, it's 75.5 years. For Hispanics, it's actually 81.8 years. And so there are differences in different ethnic groups. It's important for us at CDC that we don't just study and describe, but that we actually put science into action, and we try to explore the gaps of healthcare among diverse older populations with different social determinants and different inequities, so that we can begin to put science in action to improve health outcomes. Some of the important determinants of the diverse population over 65 from 2016 really looked at health-related quality of life. We looked at fair or poor health conditions among different populations, and including African American Indian and Native populations. Clearly, there's healthcare access issues that have been evaluated. There's obviously the importance of staying engaged in regular medical care, particularly as you get older. And there are a number of areas where individuals end up missing those appointments because of financial concerns. Obviously, there's health behavior issues, particularly that we need to be concerned about, smoking and the use of alcohol. Different ethnic groups have greater challenges here. Obviously, in some of the Native American populations, I was kind of surprised to see in our recent MMWR that looked at smoking in different populations across the country by different age groups, that actually it turned out that the Native American and American Indian population had the highest rates, which may not have surprised people in this room. But what surprised me, they had the highest rate across the board, the highest rates for cigarettes, but the highest rates for juuling, which is highest rates for the alternative tobacco uses. So clearly a lot to do. Again, this led to other issues. They also had the least amount of exercise that were engaged in their daily lifestyle, which may have some impact on the complexities that we have with weight status and obesity. But there are some good news as we begin to look at some of the health inequities across and disparities, and actually between 1999 and 2015, there's actually been a narrowing, at least of the life expectancy gap. Okay, that was the WHO. Okay, so we'll just put them on hold for a second. We've got a little bit of an outbreak going on in the DRC right now, but we'll get right back to them. Should have turned my phone off. But I will say that there has been a narrowing, of 2 years in the last 15 years between the life expectancy in African Americans and Caucasians, which is, again, progress in the right direction. And really has driven that is a decrease in heart disease. Can I give that to you? You need to figure what to do with that. Decrease in heart disease, cancer, and death rates. Again, we need to be vigilant in trying to continue to improve that. We need to understand the unique challenges that face different portions of our population across the country and begin to confront the determinants that will affect life expectancies, for example, across the board. I think we're going to see in every population there's unique health challenges. Obviously, I look forward to talking to you about that. I'd like to sort of end with to finally just ask you to do one thing for me, which is to recognize that you should never underestimate the possible, and to realize that someday, and those of you who know me in my past life, you will know the biggest thing my wife used to tell me that I happen to be Catholic. She told me that the bishops and cardinals were probably going to kick me out because I would argue with them that they need to spend their energy really focused on one of the greatest injustices that exists in the world, and that's health inequity. So never underestimate the possible, because I do believe someday health equity will become our reality, and we need to continue to recognize that that's what's required. Thank you very much. They say I have a couple minutes if there's any questions or anything. I do have about a couple more minutes. If anybody who have questions, feel free. If not, I hope you have okay, go ahead.
Sir, I have a question. I'm Fentress Truxton with the Diversity and Inclusion Management Team here at CDC. And I would like to ask you, from your travelings and discussions with some of the leaders of the world and of the state, can you tell us what you see right now is the biggest obstacle to us achieving health equity for all?
Well, I think that's an important question. I think first what I would say is what frequently is the biggest obstacle for us achieving any great thing is what I ask you to do, which is never underestimate the possible. I do believe when I talk about health equity, and I've done it for much of my career, many people think that I'm talking about something that's not in the real world. So first and foremost, we have to realize it's in the real world. Those of you who know me know that I'm a man of faith. I don't consider that a disadvantage. I don't think God intended us to have health inequity. I think health inequity is a consequence of man's choice. All right? So it's time for us to first see it's possible. It's also important for us to see that it's not what was supposed to be. And since it's a consequence of man's choice could go on a path to correct it. So I think really that's the biggest thing. The second biggest thing, truthfully, I think comes back to the individual. Health inequity is more driven by individual choice than I think some people want to recognize. You know, when my friend Dave Thatcher was Surgeon General, he did a large report on health inequity, as many of you probably know and read, because many of us believed at that time that the key to health inequity was health access. And Surgeon General Thatcher's report actually came to the conclusion it wasn't access. So again, I'm going to come back. There are social determinants of health that have an impact on health. And the reality is, if you had told me as a scientist, even 10 years ago, that things that happened to me when I was young, my father died when I was 5, life was pretty tough at the beginning, that somehow had an impact on my health when I was 65 or 67, which I am now, I would have told you there's no way that had any impact on my health. The reality is the science is showing that early events in life actually have major impact on health. So one of the more important, I was arguing that I'd like to bring a death to what we call the fifth vital sign, because I do think it helped set the stage for the opioid pandemic that we have today, that we overreacted to pain control. The real fifth vital sign we need is the social determinants of health, so that we get people to start to focus on what are the social determinants, what the air filter situation is, what the food security situation is. These are the things that are going to be really important. So I think, to me, those are the two things that I would say. You got to understand it's possible, and it's what was intended, and it was our choice that it's not there. And then I would say to really underscore the personal responsibility to begin the path for each individual to move towards life's choices that gives them a greater shot at health equity. Any other question? Yeah.
I'm going to try this. My question has to do with when you say health equity, and based on what you were saying, does that include medical training? And my contention, especially for gerontology and stuff like that, is that the training of those persons in the medical and health professions tend to temper how this thing works. So does health equity also include education of those persons coming through the system that are providing services in the health fields?
Again, a very good question, and obviously my response would be yes. Again, it goes back to whether people, the health system has to understand, the doctors and the whole system has to understand that health equity is the goal line. There is a tendency, I think, sometimes to believe that certain health conditions in certain portion of the population are not movable. Obviously, I think the experience that most physicians get in the training of geriatrics is highly inadequate. So I would agree that health equity, in order to get to health equity, we have to have a highly educated medical enterprise that understands that's the goal line. We obviously, to get health equity in different age group population, particularly the elderly and geriatrics, we have to get a health system of individuals that are trained in that. One of my proudest moments as a physician, and I cared for prior to getting deeply engaged in urban AIDS, I cared for a number of elderly individuals. And I was so proud when I finally got them almost, off all their medicines. Some people come to me like on 40 medicines, from like 32 different doctors, which they continued to refill, even though they hadn't seen those doctors. And to try to go through and say, do you need this medicine? Here's 3 medicines, ma'am. They're actually kind of the same medicine, okay? And to really get them down to maybe they're on 2 medicines or 1 medicine or even no medicines. A lot of times, I guarantee if you look at an elderly patient population, a lot of times they're on lots of medicines. And you really need trained gerontologists and physicians that can go through and take the time to understand exactly. And I will tell you, there's never been clinical studies that show the impact that the combinations of most medicines that most elderly are on. If you take the average elderly individual and they're on 10 or 12 different medicines, there's never been a study to show what those 10 or 12 medicines actually do when they're in the same person at the same time. So I take great pride in the answer is not necessarily a new prescription. But I would tell you there's a lot of healthcare professionals that have not been trained in geriatric medicine. So what you do and continue to do, I think, is very important. It's part of the solution. It's probably much more important than what I said immediately because it's more immediate. You're going to make a greater impact by training gerontologists and general internists and general medicine and family doctors and how to think about the principles of practicing medicine for the elderly. And the answer is not just more medicine.
With that being said, is there an understanding and acceptance of holistic living, eating well, exercising, to, if not complement, but maybe remove some of the pills and some of the medication for a longer, healthier life?
Well, I think you raised an important point. And again, I think, unfortunately, a lot of people, again, by different age groups that are in the medical profession do have a tendency to think that the easiest answer is another prescription. I will say, when I became CDC director, I was 235 pounds. Okay, let me just take a look here. Now, that wasn't because I came up with some great epiphany. But those of you who know me, I have a wonderful woman, Joy, who's been married to for 45 years, or 43 years, and she said, "You're the CDC director. You cannot go down there and stay at 235 pounds. You know, how can you set an example?" So I will say today I'm 214. Okay, hopefully if you come back in 6 months, I'll be 200. And that's all based on really three principles. Eating properly. And actually, my wife is pretty much a fanatic on that. She thinks we should have at least a 12-hour fast every day. So you got to figure out when you eat. And actually, there's a lot of truth to it. You can lose weight and still eat everything you do if you just don't eat for 12 hours a day, like from 7 at night to 7 in the morning. You do need to exercise. That exercise doesn't have to be strenuous. You can just walk, 20 miles a week, or 3 miles a day. And more importantly, that a lot of people don't realize, you really do need to sleep. And if you can do those things, you can start creating a healthy lifestyle. I would say that most people in medical training that are younger than the age of 50 probably don't understand how important those three elements are, and they need to have that reinforced.
I was wondering, I'm a physician, and patient empowerment, I think, patient empowerment is extremely important. And I had written this book we made into a movie called Doc Hollywood, and I came across a lot of doctors who I was able to interview for a book on symptoms that are life-threatening, so people know when to go to the emergency room. And we got the rights of that back from Random House, and now it's a free app. And we'd just like people to know that if you have a headache, fever, and can't put your chin on your chest, then you don't take aspirin and go to bed. And we're trying to figure out, how do we get the word out that that's there? It's been published in a lot of other languages. And the other question I had real quickly is, I've been involved in medical research a lot, but we're working with some Georgia Tech students on connecting people who live longer with a disease and see what they do in common. It might not be a patented drug. It could be something they're eating. And how could we get more groups to consider that type of research?
Well, your second question is easier for me in the sense that, getting big data on population health, I think, is really important. And continuing to stay, if you will, data-driven, open-minded about what it is that is associated with better health and better survival. If any of you who followed it, one decade coffee's bad, the next decade coffee's good, and then one coffee's bad. One decade drinking a glass of red wine is good, 2 glasses of red wine is good, no alcohol is bad, next year alcohol is bad. I think the only thing that we've agreed on in medicine since we finally recognized the obvious with my friend Everett Koop, who I had great admiration for him, because when we started with cigarettes, it was the cigarettes weren't the problem. You just need low-tar cigarettes, you'll be all right. And then it was, it was filtered cigarettes was first. And then maybe it wasn't the filter, maybe you needed low-tar filter cigarettes. And then Everett Koop finally came out and said, you know what? You don't need cigarettes. It's smoking that's the problem. So I do think population-based studies that can have the robustness like the Framingham study, to help people look at. And they need to include parameters that maybe they instinctually don't think should be concluded. I'm going to come back to that idea of just getting 6 to 8 hours of sleep a night. I think people underestimate how valuable that is. Obviously how valuable it is to walk 3 miles a day. I don't think that's been quantitated in a meaningful way. Your second question is, I think it's important to get proper health information to people so that they can make their own proper informed health decisions. We were just talking about that yesterday. We're having an exercise. If you've seen a lot of people around here, there's a lot of people around here, about 400, because we're doing an exercise right now on a flu pandemic. So it's sort of a mock situation for the last 3 days that we're day 35 into a major flu epidemic, to a new strain of flu, which was causing a pandemic and significant mortality and morbidity. And of course, I asked a similar question when we had our guidance to the American public. And again, this is a mock guidance, right? Because we're just going through it. But the guidance was, if you're sick, stay home, because we don't want people with flu coming to the emergency room. But I said, but we need to put a little more guidance in there, because how about if you're really sick and you're now going into respiratory failure? We don't want the person to think, well, the CDC said we should just stay home. We don't want you coming in with average flu, but we also know when your respiratory rate gets up over 22 to 25, we want you to come to the hospital. So same type of thing, because the way I would have read the message, and the CDC told me to stay home. All right, and then, so I think you're right on how you get that proper messaging. There are different things. There's obviously a number of people you can connect here. One of the important roles CDC has is in communication, in division vehicles that we communicate with the American public and the healthcare teams to constantly get people to understand what our position is on how to improve health or how to minimize health risks. So I'd encourage you, while you're here to interact and get aligned with some of the people that do that for a living. Okay, 2 more questions and we'll finish up.
Thank you very much. My name is Sonia Hutchins, and I am a professor at Morehouse School of Medicine in the Department of Community Health and Preventive Medicine. I'm a recent retiree of the U.S. Public Health Service and spent 31 years at CDC. And I was just curious to know what your thoughts are about whether you had an opportunity to look at the Health Disparities Subcommittee recommendations to the director. It's the advisory committee to the director, and whether you had time to look at their recommendations. And the reason why I bring that up is because they looked at success stories across the agency to see what we were able to do to overcome some health inequities by allocation of resources based on need. And the good example of that is the child vaccination story. And so I was wondering if you had an opportunity to look at the recommendations from the Health Disparities Subcommittee of the Advisory Committee to the Director, and what your thoughts, if you had a chance to look at those recommendations, what were your thoughts about that for the agency?
First, thanks for your service. Second, I haven't read that document, but I will. I think there's somebody in here that's taking care of me. We'll make sure I get that document so I can look through it. It's hard to put things into action if you don't do them. I remember one of the jokes that my brother and I did as a cartoon in the 1980s was a picture of President Reagan, and he was saying his horoscope, he was reading his horoscope, and his horoscope said, your legacy will be determined by your response to the AIDS epidemic. And then presidents, the cartoons that my brother drew he says, hey, Nancy, what's AIDS? And then right behind the president was about 5 congressional reports that we collected on AIDS, like the first AIDS Commission, the thing. They were all stacked behind his desk. So it was sort of a same comment that if you have reports and you don't read them and you don't put them in action, then what's the purpose of these reports? So I'll take a look at it and see if there's other ideas that we can look at. There clearly are actionable items that can make a difference. I have learned in my career, though, the biggest obstacle, this is why I keep saying it over and over again, some people think I say it too much, is the biggest obstacle is people don't think it's possible. And most people don't spend time on something they've already decided it's not possible. So the first thing you got to get people to understand is all things are possible. Okay? And I will say that when John Kennedy said he was going to put a man on the moon, 1962, right? I don't think a lot of people thought that was possible. But when Neil Armstrong walked on the moon in 1969, he did it. And I would say we didn't have the scientific solutions. Those of you who know me know one of my aspirational goals is to eliminate disease when we have the capacity to do it. And so first and foremost is to eliminate the AIDS epidemic in America. We have the tools to do it. But most people don't believe it's possible. So it's hard to get a commitment to do something that most people don't possible. Those of you who know me know I worked closely with President Bush on the PEPFAR program where we brought AIDS therapy to Africa. I was one of the first to treat people in Africa along with Paul Farmer in Haiti. And most people thought it wasn't possible. But when President Bush sent his team to see what we were doing in Malawi and they saw what Paul Farmer was doing in Haiti, they found that, wait a minute, it is possible. So then the question is, do you want to do it? And then the next question, if you want to do it, then how much is it going to cost to do it? And then once you know how much it's going to cost, then how are we going to do it? And I think the AIDS program in Africa was a great example of President Bush seeing the possible, leading the nation to act. John Kennedy, man on the moon, seeing the possible, leading a nation to act. So I would argue health equity, seeing the possible. Unfortunately, and this is where I look for other organizations to get engaged in this battle, unfortunately health equity is probably going to be a longer battle than my lifetime. But you got to get institutions committed to the possible. And whether that's government institutions, faith-based institutions, the ones that somehow seem to stay focused for the longer road sometimes are faith-based institutions. That's why if they could kind of see, be in the social conscience to get health equity as the possible, independent of their denominations, I think that would really be a great effort, because I do think it's hard for other organizations, whether it's a medical school, whether it's a health organization, to really stay on point as you're trying to do it. But we as healthcare professionals can go after incremental steps in improving health equity and decreasing health disparity. And I think what I said in my talk is we should be proud of the fact that we've made some progress, right? We still got a long way to go, but we've made some progress. But it's still true that your life expectancy is more dictated by what zip code you were born in the United States than probably anything else. And that's a problem. Was there one last question? And that's it, right there. Or we'll do if it's quick.
How you doing? I'm Kevin Williams. I'm Assistant Professor of Healthcare Leadership at Mercer University. And I'm also was in the inaugural MPH class at Morehouse School of Medicine. And I'm sitting in this room largely because I was exposed to the 5 sciences of public health through Morehouse School of Medicine and also through a program, Regional Research Center for Minority Health, working with the Office of Minority Health under Dr. Warren's leadership and Dr. Karen Bousset. And I just wanted to see what is your administration's commitment to training other workforce, the future workforce of public health practitioners, particularly minority public health practitioners, to look at these morbidities and mortality from being from the community, actually learning the science and being able to practice public health.
We just had a meeting this morning with some of my colleagues at CDC, and I was going through the 5 key core capabilities that need to be built. The third one on that list, was, of course, was workforce. And we went through some of the great programs that were implemented at CDC, the EIS program. All right. Then we looked at the next one, which was the Public Health Associates program, which is a great one, the Laboratory Leadership program. And I said, my challenge to them was, okay, what's the next great program? Because we clearly need to keep building public health capacity. What's the greatest gap that we need to try to fill right now with a historical program that, well, EIS program's historical. Tom Frieden, one of my predecessors, did the public health associates program. It's really making an impact across the country where we have people in all the health departments around the United States. He told me when he gave me advice and I took the job, he said the one thing he asked me to do was to treasure that program. I've gotten to know it. It's a great program, the laboratory leadership program. So I would tell you that workforce development is key. If any of you have great ideas where you think the greatest gap could be filled as we develop the next historical program to continue to enhance the public health workforce of this country, we're very open to it. I'm committed to try to understand what that is. You can't try to build 7 different programs at the same time and think that they're actually going to ever make an impact. So I am trying to understand during my, who knows, tour of duty. You know, it's one of the realities. It's not fun that I left a lifetime tenure job that I could have had till I was hopefully 100 years old, and you're here and you don't really know. But I do want to make sure that we make an impact on workforce that like Tom, lasts beyond me. I haven't decided where that gap is, but I know that it's an important gap. Last question, and then I got to run.
Dr. Yep, and I'm Associate Dean of Academic Affairs at the Claremont Colleges, Consortium of Liberal Arts Colleges. I'm gifted with teaching community health, health inequities in California, working alongside immigrant and refugee elders. And I appreciate your opening about an invitation for a paradigm shift, which is what is possible. And my grandma lived until she was 102, and when she was in hospice care, the social worker asked her, "What did you fear?" And she said that people will lose hope. And I think in many ways what you offered is to not lose hope. So what do you think is the biggest social determinant? We talk about social determinants of health, but what do you think are social determinants of paradigm shifts? Because you're inviting us to do a paradigm shift.
You know, that's obviously a very good question again. And, you know, I have to be honest, I'm not sure I know the answer right now. I think it is, I gave a talk. I have 2 children that are doctors. I gave a talk when they got their white coats. My son got his white coat. The dean decided to let me give the talk. He didn't know what he was getting into. And I tried to decide, what do I tell, all the 200 medical students, And so I decided to, tell them next to parenthood, I felt that medicine was the greatest vocation one could have. And of course, my son was in the audience. And then I went through a series of like 4 points. One was, continue the daily commitment to self-education. And I went through how when I was in medical school, there was not sonograms, CAT scans, there was no aids. This is a profession that you've got to stay. The second was to never deny your patients the opportunity of the advice of one of your colleagues. In other words, just never give an answer when the answer is, I don't know. That's how I triggered the story, because I gave you the answer, I don't know. Okay, and don't deny your patients the benefit, one of your colleagues. And please don't teach somebody something that you just have to teach because you don't want to say you don't know, so now you taught somebody something wrong. The third, which caused the dean to fall out of his chair, not literally, but I did see him definitely posture and tighten up. I said, and the next thing you need to do is you need to learn to love your patients. And everybody said, what? And I went through the story how my first son died and how the doctors were really brutal to my wife and I, and how a number of my patients had taught me that they were no longer just my patients. They were no longer my friends. They were actually people I really loved. And then the final thing I told them is keep a journal about your enthusiasm of medicine as you're going through it, because one day you're going to need to open up that journal and remember how enthusiastic you were. So I don't know the answer to your question. It's an important question. I think part of the theme of my answer is you got to care. And I don't think we teach that well, ironically, in a profession that is all about caring. All right, so maybe you'll come up with a better way to do it. Thank you all.
Thank you again, Dr. Redfield. Thank you.